For this talk, we'll talk about management of heart disease and heart failure. One of the key things for congestive heart failure is to confirm the diagnosis. And based on font size, I have things that are probably important for trying to be able to confirm the clinical diagnosis of congestive heart failure. Congestive heart failure, or heart failure in general, is a clinical diagnosis, so there's probably no single test that in 100% of cases will tell you whether heart failure exists or not. Certainly animals should have clinical signs compatible with congestive heart failure. And for animals with pulmonary edema or pleural effusion, radiographic evidence of congestive heart failure in 2 views is probably one of the strongest findings. The vast majority of animals with congestive heart failure have an elevated NT-proBNP, and those with right-sided heart failure have jugular venous distension with ascites, and certainly an echocardiogram compatible with bad heart disease is supportive of clinical signs resulting from congestive heart failure. If an abdominal ultrasound exam is done and the hepatic veins are dilated, this can be supportive of elevated right atrial pressure. Many animals with heart failure will have a cardiac gallop, but a gallop can also be present just due to a stiff heart. Pulmonary crackles may be noted in dogs or cats that have pulmonary edema, but pulmonary crackles can also be present in any disease process that leads to opening and closing of airways. Sinus tachycardia may be present in many dogs with heart failure, and there are some other findings there that might be supportive of a diagnosis of congestive heart failure. But realistically, having several of the first 2 or 3 or 4 of these items on your list is important to establish a diagnosis of congestive heart failure. Previously, we reviewed that there is neurohumoral activation associated with the development of congestive heart failure, and one of the things to emphasize in this lecture is that most of the effective drugs for heart disease block one of these neurohumoral activations, including the sympathetic nervous system, the renin-angiotensin system, natriuretic peptides, and a variety of other things on this list. How do we pick drugs to treat heart disease in veterinary medicine? Well, we might not all go about it in exactly the same way. The weakest way, although often is the inclination of many students, is to do it based on mechanism of action of a particular drug. A mechanism of action of a drug is important to know, but that's not, in most instances, how you would decide to pick a drug for management of heart failure. Another thing that could be supportive would be improvement in a blood test, such as BNP, troponin, or kidney values, but these are rarely used as the main yardsticks for picking a medication. Unfortunately, many of us use our anecdotal reports and/or our clinical experiences based on our experience of certain cases, and our preferences then impact how we're going to go ahead and manage a case. For many veterinarians, they rely on the opinion of a specialist that they work with, and that specialist or the primary care veterinarian might read consensus statements developed to try to help direct therapy and direct diagnostic testing. These consensus statements are usually based on evidence-based veterinary medicine. And evidence-based veterinary medicine usually means there's been a clinical trial and some publication that has hopefully investigated an outcome of interest. And for animals with heart failure, the 2 key heart failure outcomes of interest are either prolonged survival or prolonged time till deterioration, or improved quality of life, which can be assessed by fetch or catch questionnaires. You're probably familiar with this or a similar evidence-based veterinary medicine pyramid, which again, the mechanism of action forms the bottom level of the pyramid, and you would prefer to pick from something much higher up on the pyramid rather than based on a mechanism of action. In people with heart failure, there are many clinical trials, and those clinical trials clearly show improved outcome, improved survival, quality of life as a result of administration of ACE inhibitors, beta blockers, aldosterone receptor antagonists, angiotensin receptor blocker, neprilysin inhibitors, SGLT2 inhibitors, or a special form of fish oil, icosapent ethyl. Whereas the supporting evidence for furosemide and digoxin is lower on the pyramid. In animals with congestive heart failure, we have far fewer studies, but we do have a few studies that support the idea that Pimobendan and ACE inhibitors may be helpful, particularly in dogs with congestive heart failure. For cats and other species, there's a lot less evidence to support the ways that animals should be treated, and a lot of it depends on retrospective studies or opinion of an expert. There is some evidence for torsemide and spironolactone leading to an improved outcome as well. So we'll keep this in mind as we try to go through the various medications and which ones we might use for management of animals with heart failure. One of the other things to think about are what are the causes of death, which are best known in dogs and cats with congestive heart failure. Sudden death, usually as a result of a cardiac arrhythmia, may occur in 10 to 40% of dogs, with a higher proportion, 30 or 40%, in dogs with dilated cardiomyopathy. Sudden death is less common, maybe happening in 10 or 15% of cats with heart failure. Thromboembolic disease is especially likely to happen in cats, especially those with marked left atrial enlargement and congestive heart failure. Some animals die from refractory congestive heart failure after we've run out of medications or from an acute recurrence of severe pulmonary edema. Yet euthanasia probably accounts for the cause of death in the majority of dogs and cats with heart failure. Probably 40 to 60% of dogs and cats with heart failure die as a direct result of euthanasia after a discussion with a veterinarian. The factors that impact that decision include a reduced quality of life, recurrent heart failure in need of additional cardiac visits or medications, loss of appetite or weakness in the animal, and especially a poor prognosis offered by the primary care or attending veterinarian. Owners will rely upon the veterinarian to make a recommendation at what point in time they should think about quitting. And if a poor prognosis is offered, it's likely the owner will decide it's time to quit. This becomes more important when we think about the perceptions and priorities of owners, especially dogs with significant heart disease. In this particular study, owners were asked if they would trade perfect quality life for a certain amount of time, and many of the responders suggested that they would trade 6 months of survival time for perfect quality of life. This emphasizes that quality of life should be an important thing that we think about when trying to manage congestive heart failure. Which drugs do we use? Certainly the ones with gold stars would be the ones most frequently used to manage congestive heart failure, but there's a number of other drugs that we might use, and we're going to talk about some of those right now. Dakota is going to help us here in management of congestive heart failure. Dakota was an 11-year-old male American Staffordshire Terrier that had congestive heart failure and came back to see us multiple times to have medication adjustments. His previous diseases include a bad hair coat and recently some weakness and shortness of breath, and the acute presentation was for 2 collapsing episodes that happened today. On exam, he had a 3 out of 6 systolic murmur over the left apex near the mitral valve, and marked cardiac arrhythmia. His arterial pulses were variable in quality, but most of them were weak, and the jugular vein was distended 3/4 of the way up the neck. He had harsh bronchovesicular sounds, but no clear crackles. Body condition score was 6, and he had abdominal distension with fluid wave and cranial organomegaly. His initial ECG identified a serious arrhythmia, both atrial fibrillation as well as 6 or 7 beat runs of ventricular tachycardia. We'll need to think about both of those in therapy, perhaps. Thoracic radiographs is the DV view. He had cardiac enlargement of all 4 cardiac chambers, especially left atrial enlargement, pulmonary vein distension, and a mild interstitial pattern to the lungs. On echocardiography, Dakota had 3+ mitral regurgitation and 2+ tricuspid regurgitation. He also had markedly dilated left ventricle with reduced left ventricular contractile function. His left atrium was also markedly enlarged with enlargement of the right ventricle as well as the pulmonary artery. Sonographic exam of the abdomen documented a moderate to large volume of ascites. These findings probably indicate concurrent myxomatous mitral valve disease as well as myocardial failure, perhaps concurrent dilated cardiomyopathy. So if we go through the diagnoses, we would identify that there's mitral valve regurgitation with reduced contractile function, atrial fibrillation, ventricular tachycardia, and yes, the dog does have congestive heart failure. And the next thing for us to do is to outline a treatment plan, and as we outline that treatment plan, we may want to think about what side effects we're going to tell the owner to watch for, when we want to see Dakota back for a recheck exam, and what we might do on that recheck exam. And we'll go through some of that story as we go through Dakota's case. His initial therapy was furosemide 50 milligrams orally twice a day, Pimobendan 10 milligrams orally twice a day, Digoxin, an extended release version of diltiazem, and we discussed dietary therapy with sodium restriction as well as omega-3 fatty acid supplement, as well as discussing exercise limitation. During hospitalization, after initial management of heart failure and treatment of atrial fibrillation, the ventricular arrhythmia was much less frequent, so we decided to not add in a specific ventricular antiarrhythmic at that time. The plan was to recheck Dakota in 10 days and add in an ACE inhibitor at that time. So let's talk about these drugs a little bit. Furosemide is the first medication, and furosemide is typically indicated for fluid accumulation due to cardiac disease. So cardiogenic edema that's manifest as either pulmonary edema, pleural effusion, or ascites. Furosemide is the most commonly used diuretic in veterinary medicine. It's a loop diuretic working on the ascending limb of the loop of Henle to block chloride and other electrolyte resorption. And along with the chloride and other electrolytes staying in the renal tubule, water follows those out into the urine. Furosemide's been described as a high ceiling diuretic, which to me means it's got a wide dose range. If you give a low dose of furosemide, you get a mild diuretic effect. If you give a large dose of furosemide, you get a very impressive diuretic effect. And especially if furosemide is given intravenously, you may see a diuretic effect as soon as 30 minutes later. Side effects are almost always due to excessive furosemide administration. So excessive furosemide administration can lead to dehydration, azotemia, which is usually pre-renal, electrolyte depletion, including hypokalemia, hypochloremia, hyponatremia, hypomagnesemia, as well as metabolic alkalosis. Less commonly, furosemide can cause vomiting or pancreatitis or blood dyscrasia, and deafness has been described with rapid administration of furosemide intravenously.
We might think about two settings for when we'd give furosemide. The first is chronic congestive heart failure therapy, and the second is for emergency management of congestive heart failure. For chronic therapy, we might start with a low dose of furosemide of 2 milligrams per kilogram once or twice a day. And as heart failure advances, we can increase that dose up to 4 milligrams per kilogram 3 times a day or even higher. And sometimes we would give injectable furosemide in addition to oral. Often we use a lower dose of furosemide in cats, and diuretic resistance to furosemide can develop over time. If we suspect diuretic resistance is occurring because we're using a high dose of furosemide and not seeing a diuretic effect anymore, we might use additional diuretics that work on other sites in the nephron, or review sodium intake and treats that the owner might be giving to the animal. For emergency management of congestive heart failure, especially for severe pulmonary edema, furosemide can be administered 2 to 4 milligrams per kilogram intravenously Q1 hour, up to 3 times or until improved, and then the frequency is usually dropped off. Or if after a couple of doses of IV furosemide is not working, we might pick another drug like sodium nitroprusside. Some people prefer to use a continuous rate infusion of furosemide in the situation of emergency or refractory pulmonary edema. Furosemide as a continuous rate infusion for acute pulmonary edema is proposed to create a greater diuretic and natriuretic effect, potentially with fewer side effects or fewer electrolyte changes. Doses of 0.1 to 1 milligram per kilogram per hour, or some people use as high as 2 milligram per kilogram per hour, are formulated for continuous rate infusion in a small volume of 5% dextrose in water. The largest study to date, done in people with acute congestive heart failure, failed to show any benefit of continuous rate infusion of furosemide as opposed to bolus administration of furosemide.
Dakota was treated with Pimobendan. Pimobendan is a calcium sensitizer that enhances the interaction of the actin and myosin filaments, so it's a positive inotrope. It also has phosphodiesterase 3 inhibitor activity, which could give it a little additional positive inotropic effect, but also makes it a vasodilator. Thus, Pimobendan is a positive inotrope with vasodilator properties and is sometimes referred to as an inodilator. The drug is rapidly absorbed after oral administration, usually achieving blood levels within 1 hour. And it's approved for use in dogs with congestive heart failure due to myxomatous mitral valve disease or dilated cardiomyopathy. 2 quick studies looking at Pimobendan in dogs with dilated cardiomyopathy. The first one, we're going to concentrate on the Doberman pinchers that had background therapy of furosemide ACE inhibitor and digoxin and either got Pimobendan or got a placebo. And if we go ahead and look at this graph on the lower portion here, we're looking at the median survival time, the time until 50% of the dogs had dropped out of the study, which for those that were treated without Pimobendan, that happened at about 50 days. And for those that were treated with Pimobendan, that happened around 329 days. So this is going to be one of our main yardsticks in evidence-based veterinary medicine. Is there a prolongation in survival time or time until the animal drops out of a study? And if so, is that a meaningful amount of additional time rather than just a statistically significant amount of time? So in this case, we'd say yes. And a second study looking at a small number of Dobermans with heart failure that were randomized to either get placebo or Pimobendan had a similar outcome with 130 days survival time for the Pimobendan treated dogs versus only 14 days for the placebo treated dogs. So Pimobendan seems to be clearly helpful for Doberman pinchers with dilated cardiomyopathy and congestive heart failure. One of the other main studies we rely upon is the QUEST trial, which looked at dogs with myxomatous mitral valve disease and congestive heart failure. It was a large study with 260 dogs, and dogs were randomized to either Pimobendan or benazepril, with a background of furosemide, digoxin, and spironolactone given to some dogs. The median survival time for all dogs was about 188 days, and this is what we often see in dogs with congestive heart failure. From the onset of congestive heart failure until the end of survival is often somewhere in the 180 to maybe 230 days in a number of different trials. So that's what we often tell owners, is that if we can get your dog with new onset heart failure 6 months, we've done a good job. If we get them a year, we've done a really good job. And in this particular study, the Pimobendan treated dogs lived 267 days compared to the benazepril treated dogs 140 days. That was statistically significant. And again, most owners would identify that as a clinically important prolongation of survival time for their dog with heart failure. Pimobendan, compared to some of the other cardiac medications, has relatively few side effects. Most of the other cardiac medications have predictable side effects that happen in certain situations. Pimobendan might be associated with diarrhea or gastrointestinal upset, perhaps cardiac arrhythmia, although that's uncommon, and maybe increased excitability. We've talked about use of Pimobendan in dogs that have congestive heart failure. There are 1 or 2 trials looking at Pimobendan use in animals with early disease before the identification of congestion. And this study looked at a fair number of Doberman pinschers with occult DCM, and they were randomized to either a placebo or to get Pimobendan. And the main endpoint was the onset of heart failure or sudden death. And if we look at the results, the median time to the primary endpoint for the Pimobendan group was much longer than the placebo group. And the median survival time, to include the period of heart failure, was also longer in the Pimobendan group compared to the placebo group. Another large study looked at dogs with myxomatous mitral valve disease who were asymptomatic. They did not have congestive heart failure yet. They did not have clinical signs. And this study targeted dogs with myxomatous mitral valve disease and moderate cardiac enlargement. And enrolled dogs had to have all 4 of the following: at least a 3 out of 6 murmur, left atrial enlargement, left ventricular enlargement based on that criteria, and a vertebral heart size on thoracic radiographs greater than 10.5. And in this study, the Pimobendan treated dogs lived longer than the placebo treated dogs until the onset of congestive heart failure. And the prolongation of time until congestive heart failure was quite significant, almost an extra 15 months period of time. There was no increased adverse events in the Pimobendan group, and the overall survival time for dogs treated with Pimobendan was longer than those treated with placebo as well. We know a lot less information about Pimobendan use in cats. Retrospective studies suggest that most cats tolerate Pimobendan fairly well, although there are concerns about administration of Pimobendan to cats that have left ventricular outflow tract obstruction with systolic anterior motion of the mitral valve. The doses used in cats are often similar to those used in dogs, and some cats respond favorably, with at least 1 retrospective study suggesting improved outcome. Digitalis glycosides have been used for years. Dakota was put on Digitalis for atrial fibrillation, not for management of heart failure. Digitalis comes from a foxglove plant, and there's a variety of formulations, although we're going to concentrate on Digoxin. There's 2 main categories of effects of Digitalis glycosides. The first is it's a positive inotrope by blocking the sodium-potassium ATPase pump. And the second, which is the more important reason for use of digitalis today, is the vagomimetic effect. It slows heart rate, it slows AV conduction, which forms the basis for its use in atrial fibrillation or supraventricular tachycardia, and it has a little bit of an atrial antiarrhythmic effect. It also can reduce sympathetic output and may improve baroreceptor function, and for that reason it might be used in some animals that have recurrent syncope. A quick comparison of digoxin versus digitoxin, and while digitoxin has some theoretical advantages, digoxin is the one that is most commonly used in veterinary medicine. Note that it has elimination by the kidneys, so anything that limits kidney function can result in elevation of blood digoxin levels. And the half-life is around a day or a little bit longer than that in a dog, and probably 1 to 3 days in a cat. That will be important when we think about how long we might withhold the drug in a situation of potential toxicity. Again, digoxin has a renal elimination. It comes in a variety of different formulations, tablets and an elixir and an intravenous formulation, although we rarely use the IV formulation due to a high side effect rate. The elixir is absorbed better than the tablets, so we might reduce the dose if we're going to give the elixir. And there are some proposed dosing strategies there for dogs, cats, and horses. Digitalis can create a variety of electrocardiographic effects, and the ECG effects for digitalis administration, when you're at an appropriate level, sometimes overlap with those seen with digitalis intoxication. We can see a slowed heart rate, a prolonged PR interval for animals in sinus rhythm or AV block, shortening of the QT interval, ST segment changes including ST segment slurring or coving, and junctional or ventricular arrhythmias are particularly likely in dogs or cats with digitalis intoxication. The main clinical use for digitoxin these days is to treat supraventricular tachyarrhythmias, in particular atrial fibrillation. The vagomimetic action slows AV conduction and thus slows the heart rate. We sometimes use digoxin to treat recurrent syncope in dogs with myxomatous mitral valve disease who have syncope despite control of congestive heart failure. Again, it may improve baroreceptor function. This seems to be particularly useful in some small white-haired dogs. It can also be used to treat congestive heart failure because of the positive inotropic effects, although it's infrequently used for the main reason to treat congestive heart failure today. One of the reasons digitalis is limited to certain settings is the potential for intoxication. And signs of intoxication can include anorexia, lethargy, depression, vomiting, diarrhea, and cardiac arrhythmias, especially AV block or slowed conduction through the AV node. Animals are predisposed to digitalis intoxication if they have kidney insufficiency, hypokalemia or hypomagnesemia, reduced skeletal muscle mass since digitalis also binds to skeletal muscle, advanced aged, dosing without consideration of ascites since digitalis is not distributed into acidic fluid, and there are certain drugs that can interact with digitalis as well. This ECG is from a dog that had digitalis intoxication and atrial fibrillation with a very slow ventricular response. We might monitor blood digoxin concentrations in an attempt to try to reduce the chance of getting toxicity. The diagram on the bottom shows that there's a distribution phase, usually lasting the first 6 or 8 hours, and then an elimination phase, and it would be desirable to sample during the elimination phase. That's where the target blood levels have been determined. So we're usually going to obtain a sample around 8 hours after pill administration. The therapeutic range has been proposed to be between 0.8 and 2 nanogram per ml, which is very close to the toxic range, which may start to occur anywhere in the 2.2 nanogram to 2.5 nanogram per ml range. And this is often termed a narrow therapeutic index or a narrow therapeutic window when the therapeutic range is very close to the toxic range of a drug. In an attempt to avoid toxicity, which might lead to euthanasia in some owners if they think their animal's quality of life is reduced, we usually aim for a lower therapeutic range, somewhere in the 0.8 to 1.2 nanogram per ml range under the green bar, again obtained approximately 8 hours post-pill administration. Dakota was also treated with diltiazem, which is a class 4 antiarrhythmic. This shows a sustained release formulation of diltiazem. The capsule is 240 milligrams, but if you open the capsule up, there's 4 tablets inside. Each of those tablets is 60 milligrams, and we sometimes cut the tablet in half to try to get down to a 30 milligram dose in certain animals. The other class 4 antiarrhythmic, which is calcium channel blocker, is the group, is amlodipine. And amlodipine is usually used to try to reduce blood pressure in dogs and cats. So possible clinical uses of class 4 antiarrhythmic drugs, calcium channel blockers, include supraventricular tachycardia or atrial fibrillation, systemic hypertension, with amlodipine being the one used most frequently in veterinary medicine, hypertrophic cardiomyopathy, and perhaps coronary vasodilation. Side effects are sometimes seen with calcium channel blockers, in particular when diltiazem is given intravenously too quickly or in too high a dose, and that can lead to excess negative chronotropism, so a major drop in heart rate, either sinus bradycardia or AV block. Both of these animals had major AV block as a result of excess administration of diltiazem. Can also have a negative inotropic effect, a reduction in the vigor of contraction of the heart, which might precipitate heart failure or weakness. And excess calcium channel blocker administration can lead to excess vasodilation and hypotension as well. Centesis is often indicated, and again, with a large volume of ascites like Dakota had, it may be worthwhile to tap some of the fluid from the abdomen. So for thoracentesis, removing fluid from the chest, we would remove if that fluid was judged to be causing difficulty breathing, and usually if we're going to tap the chest, we'd remove as much pleural effusion as possible. Whereas for abdominocentesis, we would remove some of the fluid if it was causing difficulty ambulating. Sometimes the extra weight of that fluid makes it hard for animals to get up and move around. If it was affecting appetite, and sometimes a large volume of ascites will reduce blood flow to the GI tract and affect appetite. Or if there was enough fluid that it was pressing on the diaphragm and contributing to shortness of breath. We may not remove all of the fluid in there. Part of the reason is that repeated centesis of abdominal fluid can lead to protein loss and cachexia. So we'd remove some in order to try to improve clinical signs, but we might then try to adjust cardiac medications to try to mobilize the fluid with higher doses or additional cardiac drugs. We also would talk to the owner about whether they're feeding a diet that's higher in sodium and or whether they're getting people food or treats, or whether they're giving drugs, the drugs in treats that are high in salt or sodium. So we wouldn't usually change the diet right off the bat. We might wait, make sure the animal tolerates the medications, and then in 5 to 14 days try to slowly introduce in some of the new diet, maybe a quarter of the new diet, 3/4 of the old diet, eventually get to 50-50 until you've transitioned over to the new diet. And the HeartSmart website, which you can find by searching Tufts and HeartSmart, will give you diet options that are somewhat restricted in sodium. Exercise limitation, there may be a little debate as to whether exercise limitation is good or not, but for the most part, we are not rehabilitating hearts. We're trying to have animals be comfortable with advanced heart disease they already have. So in animals with mild congestive heart failure, we would recommend no repetitive activities, avoiding exercise to exhaustion, and perhaps if owners want to take their dog on a walk on a leash, if the dog starts out in front and pulling on the leash, if they get to the point where the dog is walking by their side, that's probably far enough, and they probably should try a shorter walk the next day. For animals with severe congestive heart failure, cage rest only is recommended until they're breathing more comfortably. Dakota was rechecked for congestive heart failure at 10 days. He was doing okay. He still had some ascites, but less ascites and no collapse. He'd been started on an early cardiac diet with instructions for sodium restriction of treats. The owners were able to get the medications in as directed. His BUN had climbed up a little bit to 46. The creatinine was still okay at 1.7. The ECG just had atrial fibrillation. The rate was still maybe a little faster than desired, but the ventricular arrhythmia was no longer present. And we submitted a blood digoxin level approximately 8 hours after pill administration to make sure the blood level was okay. At the 10-day recheck, we continued with the prior doses, but we added in an allopril. We started at a low dose at 10 milligrams once a day. The renin-angiotensin system is important in the body's attempts to hold on to sodium and water, as well as cause a degree of vasoconstriction. Reduced perfusion of the kidney leads to activation of the renin-angiotensin-aldosterone system, and as angiotensin II is formed, it causes vasoconstriction, release of aldosterone, increased thirst, increased antidiuretic hormone release, and sympathetic stimulation. One of the other effects of angiotensin II is that it can contribute to progressive hypertrophy or fibrosis in the myocardium. ACE inhibitors have been studied in dogs and in people. And in dogs, ACE inhibitors improve survival. There's 2 studies listed there, and they improve clinical signs in dogs and cats with heart failure. They may slow cardiac remodeling in certain situations. And ACE inhibitors may delay the onset of congestive heart failure in some cases, but usually that's going to be in situations with a dilated hypocontractile heart, not with mitral valve disease. Again, one of the bigger studies in dogs with congestive heart failure looked at benazepril versus placebo, and the benazepril-treated dogs lived for 428 days, whereas the placebo-treated dogs only lived 128 days. Why would you use an ACE inhibitor? Well, you might use it for an animal with heart disease, especially if they have congestive heart failure, as it may improve clinical signs or improve survival time. You might use ACE inhibitors for systemic hypertension in an attempt to try to reduce blood pressure. ACE inhibitors, as well as angiotensin receptor blockers, might be used to reduce proteinuria. And in certain situations, they may lead to they may delay the onset of congestive heart failure. And that might be true for dogs with dilated cardiomyopathy, but probably there's a lesser effect on delaying heart failure in dogs with myxomatous mitral valve disease. One of the bigger studies was run by Kvart et al. And looked at a low dose enalapril versus placebo, and again saw no difference in the time until onset of heart failure. General therapeutic recommendations for ACE inhibitors: we would usually try to have an ACE inhibitor in the mix for dogs or cats with congestive heart failure. The role in management of horses with congestive heart failure and other species is a little bit less clear, although they are often used. When we're using an ACE inhibitor with a diuretic like furosemide, we usually try to give the lowest dose of furosemide that will control signs of congestion. And then measure and follow renal function, so get baseline kidney value and electrolytes, and then repeat those 5 to 14 days after starting the ACE inhibitor. ACE inhibitors can cause hypotension, so we would delay use of ACE inhibitors in animals that already have hypotension. And it's a little bit less clear as to whether ACE inhibitors will delay the onset of heart failure or not. In general, our rule of thumb is the bigger the left atrium is, the more likely we might add an ACE inhibitor into an asymptomatic animal. Potential side effects of ACE inhibitors include hypotension. Thus, we would delay use in animals that are dehydrated or with low or borderline low blood pressure. Azotemia, which is usually due to excessive concurrent diuretic administration, and the azotemia usually resolves with a reduction in the dose of diuretic. Renal failure is a rare complication, especially in animals with prior significant renal disease. ACE inhibitors sometimes cause vomiting, diarrhea, or loss of appetite. Often that's seen when you're giving too much of a diuretic as well. And one side effect that's commonly reported in people, but is uncommon in dogs and cats, is cough. 1 month after the onset of congestive heart failure, Dakota was seen. He was doing well per the owner, but still had some ascites. They were doing well with giving the medications and sticking with the diet and exercise limitation. The BUN had now come back to a nearly normal range, and the atrial fibrillation rate was better. Abdominal ultrasound was done to look for other possible causes of ascites, and none were found. So again, the consensus was the ascites was still due to congestive heart failure, and perhaps some dose adjustment was appropriate. At this point in time, we increased the enalapril to 10 milligrams twice a day from once a day and started spironolactone. Spironolactone and eplerenone are identified as potassium-sparing diuretics. They are aldosterone receptor antagonists, and one of their effects is to conserve potassium. So they're sometimes used to counterbalance hypokalemia of loop or thiazide diuretics. Spironolactone has a relatively mild diuretic effect, and it's sometimes hard to show it has any diuretic effect at all in a healthy dog. It can help to restore baroreceptor function toward normal, and these drugs have clear improved survival time in multiple human heart failure trials, and there's one study that suggests possible benefit in dogs with congestive heart failure. The main side effects of aldosterone receptor antagonists can include hyperkalemia, especially at higher doses, lethargy, weakness, or anorexia, and sometimes they cause GI signs, which can sometimes be reduced if the drug is given with food. 2 months after the onset of heart failure, Dakota presented with more ascites, and he had 2 more collapsing episodes. The owners were giving the medication as directed. His kidney values are relatively stable, and he had atrial fibrillation with rare ventricular premature depolarization. The assessment was that most of his issue was worsening congestive heart failure. So we increased the furosemide to 3 times a day, and we increased the Pimobendan as well. Pimobendan has been described to be used at higher doses than recommended on the label. Sometimes we give 3 times a day dosing or go up as high as 0.6 milligram per kilogram twice a day, sometimes even higher than that. 3 months after the onset of heart failure, Dakota presented for anorexia and diarrhea. He still had ascites. 1.7 liters of the serosanguinous fluid was tapped away. The owners were giving medications as directed. The BUN had started to climb up a little bit, and the ECG had similar findings to before. The assessment was that Dakota had worsening heart failure, but there was worry that the anorexia and diarrhea might be a result of Digitalis Intoxication. So Digoxin was held with plans to restart a few days down the road, increase the Pimobendan again, and now add in torsemide. Torsemide is a loop diuretic. and it has minor potassium-sparing properties as well. It's often effective diuretic at quite low doses compared to furosemide, so it's much more potent than furosemide. It's often dosed at somewhere between 1/10 and 1/20th the dose of furosemide that you would hope to give to achieve a particular diuretic effect. When diuretic resistance is suspected to be present, some clinicians will do option 1, where they take away furosemide and replace it with an equivalent amount of torsemide. And option 2 is to continue with the same dose of furosemide but start to slowly add in torsemide to try to control congestive heart failure. One of the newer things is that some people are routinely starting to pick torsemide instead of furosemide as their first diuretic of choice. So at some point in time, it may be that the initial diuretic of choice is torsemide instead of furosemide. And there's less experience with torsemide in cats than dogs. 4 months after the onset of heart failure, Dakota was doing well. There was still ascites, but the GI signs had resolved. The kidney values were improved. The ascites was bad enough that 3.1 liters of fluid had to be tapped. So again, worsening right-sided congestive heart failure, and it was documented that Dakota now had pulmonary hypertension. And with pulmonary hypertension and refractory right-sided heart failure, the change was made is that we added in sildenafil. So sildenafil is a vasodilator, and we might think generically about different types of vasodilators. Venous vasodilators like nitroglycerin, which dilate the systemic veins and move blood away from the heart and lungs. Thus, it reduces preload. We might think about our drugs that have predominantly arterial vasodilator activity, like amlodipine. They dilate systemic arteries. They unload the left ventricle and hopefully then allow increased blood flow forward with less mitral regurgitation. Balanced vasodilators dilate both arteries and veins, and sodium nitroprusside might be an example of a balanced vasodilator. Whereas pulmonary artery vasodilator would be sildenafil, which is what we added into our dog, and that's usually used to treat pulmonary hypertension. So sildenafil, typically used for pulmonary hypertension due to heart failure or pulmonary hypertension due to other causes. Sildenafil is a phosphodiesterase 5 inhibitor, thus a nitric oxide donor, which is important in pulmonary vasodilation. It's useful in dogs with pulmonary hypertension, can improve clinical signs resulting from pulmonary hypertension, and sometimes causes a modest reduction in pulmonary artery pressure. It's usually recommended that nitrates not be given concurrent with sildenafil, as this may create significant hypotension. Doses are proposed either 2 or 3 times a day. We usually find that 3 times a day works better. Tadalafil has also been reported. In our hands, sildenafil works better than tadalafil. And in chronic heart failure, if there is moderate to severe pulmonary hypertension as measured by echo, or if they have clinical signs that we think are related to pulmonary hypertension, we might add in sildenafil. Nitroglycerin, as we said, is a venous vasodilator, although it also dilates coronary arteries. It's usually administered transcutaneously in veterinary medicine, but it can also be administered intravenously. If you administer it transcutaneously, you should wear gloves. It can be absorbed through your skin as well. It comes in this toothpaste type of tube, and you squirt a little bit out and smear it onto a hairless region of the animal. Typically, it's used for severe pulmonary edema for 1 to 3 days. If you continue to use it, tolerance can develop and the drug is no longer effective, so other drugs need to be started. For chronic management of heart failure, some people have used it in combination with multiple cardiac drugs, and side effects can include headache, hypotension, lethargy, and azotemia. Amlodipine is the classic arterial vasodilator that is sometimes used for management of congestive heart failure. It's a calcium channel blocker that has predominantly arterial vessel selectivity and relatively limited direct cardiac effects in a clinical setting, so it's not likely to reduce heart rate or slow AV conduction. Thus, amlodipine is used mostly to treat systemic hypertension in dogs and cats, or can be used in dogs with mitral regurgitation due to myxomatous mitral valve disease and refractory heart failure, especially if their blood pressure is okay or at the upper limit of normal. Sodium nitroprusside is a balanced vasodilator. It's a very potent and effective drug, and it's my second favorite drug for management of acute severe pulmonary edema. It has a very short duration of action, thus must be given as a continuous rate infusion, and ideally you'd like to follow blood pressure, because if you give too much drug you'll create severe hypotension. Thus, with a continuous rate infusion and need to follow blood pressure, it requires an ICU type of environment for use. It's very effective for severe pulmonary edema, usually used somewhere between 1 and 3 days with concurrent diuretic to try to clear pulmonary edema. The drug is sensitive to light, so we would usually wrap it. As you look at the cat in the cage getting nitroprusside, you can see the line is wrapped and that the infusion pump is in a bag to protect it from light. Side effects include hypotension, GI side effects, or when high doses are given for multiple days, there's a potential for cyanide intoxication. Dakota continued to get periodic rechecks to try to adjust the cardiac medications. So 11 months after the onset of heart failure, he'd been to see us in cardiology for 12 additional visits. He now had no ascites and was doing better after multiple medication adjustments. His BUN was up to 90, his creatinine was still at the upper limit of normal, and he did have electrolyte depletion. The ECG was unchanged, and he was assessed to be stable on his current medications, although there was concern about azotemia, that the price of being able to clear his ascites was a significant rise in BUN. We decided to go ahead and try to make a little additional adjustments to therapy at this point in time. You can see some of those adjustments there. One of the adjustments was to try to add in hydrochlorothiazide, which is a thiazide diuretic. Hydrochlorothiazide and chlorothiazide are available. They inhibit sodium and water absorption in the distal tubule of the kidney. They're relatively weaker diuretics than loop diuretics, which is part of the reason loop diuretics are often picked first. And thiazide diuretics are often relatively ineffective if there's pre-existing renal failure. These drugs can lead to electrolyte depletion, and for the most part they're used in combination with other diuretics in situations where diuretic resistance is suspected. 14 months after the onset of congestive heart failure, so Dakota has done better than usual, dog with heart failure. Again, he had some collapsing events and had loss of appetite and was just doing poorly overall. Came in through the emergency service and he was admitted to the hospital for medication adjustments. He responded poorly to the medication changes and he was started on a dopamine infusion to try to support blood pressure. So this takes us to positive inotropes, the sympathomimetic amines. There's 5 of them there: dobutamine, epinephrine, norepinephrine, dopamine, and isoproternol that we'll talk about in a minute. We've already talked about digoxin, and we've already talked about pimobendan. We'll talk just a little bit about milrinone and amrinone as phosphodiesterase 3 inhibitors. All of the sympathomimetic amines have a short half-life along the lines of a couple of minutes, so they're given by a continuous rate infusion. and they stimulate various adrenergic receptors. Alpha-1 receptors, when stimulated, cause vasoconstriction to try to raise blood pressure. Beta-1, which are predominantly in the heart, when they're stimulated, they cause positive inotropic and positive chronotropic effects. Beta-2 receptors, which are, some of them are located on the heart, but more on blood vessels and on bronchi. When beta-2 receptors are stimulated, they cause vasodilation and bronchodilation. And dopaminergic receptors are present in the coronary, cerebral, mesenteric, and renal arterioles, and they may cause vasodilation. So each of the different sympathomimetic amines has different effects on these sympathetic receptors. Some are more alpha specific, some are more beta specific, and depending on which receptor they fit best into, you will get a different type of effect from administration of the drug. Let's talk about dobutamine first, which has predominantly beta-1, a little bit of beta-2 and alpha effect, but predominantly beta-1 effect. Thus, it's a positive inotrope. It can increase cardiac output. It often has limited effect on heart rate and, thankfully, limited arrhythmogenesis. And administration of dobutamine usually results in minimal change in blood pressure. Thus, it's perhaps most frequently used in the setting of acute congestive heart failure with evidence of reduced cardiac output. It's given as a continuous rate infusion for 1 to 4 days, after which tolerance can start to develop. Because it can cause arrhythmia, ECG monitoring is recommended, so it's usually administered in an ICU type of environment. Epinephrine is the next one to talk about, which has a lot of beta-1 and a lot of alpha effects. Thus, it has a positive inotropic effect, a positive chronotropic effect, as well as creating a significant rise in blood pressure. It has significant potential for arrhythmia formation, especially at higher doses. The main use for epinephrine is during cardiopulmonary resuscitation, and usually boluses of epinephrine are given every 2 to 4 minutes during the course of cardiopulmonary resuscitation in an attempt to try to both stimulate the heart and increase blood pressure. Norepinephrine is the next one to talk about, which again has predominantly beta-1 and alpha-1 effects. Thus, it has a positive inotropic and chronotropic and potential for arrhythmogenic effect, but it's mostly used for its ability to raise the blood pressure. It's used in a setting of animals with really significant low cardiac output and refractory hypotension after they've received fluids and other therapies, and those therapies have failed to raise the blood pressure. So it's given as a continuous rate infusion, perhaps in an animal with septic shock and hypotension, to try to raise blood pressure. ECG and blood pressure monitoring is indicated again, so this is typically used in an ICU environment. Dopamine is also sometimes used in veterinary medicine. It has both alpha and beta-1 effects, and the dose that you give may determine the amount of effect that you have to either increase cardiac output, heart rate, blood pressure, or renal perfusion. The likelihood of raising blood pressure with dopamine is greater at higher doses. If you get up to 10 microgram per kilogram per minute or higher, you're more likely to get a rise in blood pressure. So dopamine is given as a continuous rate infusion with ECG monitoring to watch for arrhythmia in an ICU environment. Isoproternol is a prototypic beta agonist with beta-1 and beta-2 activity and virtually no alpha stimulation. Thus, it has a positive inotropic and chronotropic effect with significant potential for arrhythmia, but no ability to raise blood pressure. And sometimes you could even get a drop in blood pressure because of the lack of alpha stimulation. It's rarely used in veterinary medicine, but can be used for severe bradycardias. Let's talk for a minute about other phosphodiesterase inhibitors. amrinone and milrinone. We've already said that pimobendan also has a little bit of phosphodiesterase inhibitor effect. These are selective cardiac phosphodiesterase 3 inhibitors that result in a positive inotropic effect to increase cardiac output and a vasodilator effect to make it easier to pump blood forward. Human clinical trials identified that arrhythmia can develop and that these drugs were mostly associated with increased mortality compared to placebo when used for chronic management of congestive heart failure. Thus, currently they are typically used for short-term support of cardiac function and blood pressure in an ICU environment. What about beta blockers and congestive heart failure? Beta blockers are highly valuable for use of treating heart failure in people with congestive heart failure. They're much less commonly used in veterinary medicine. Why would we use a beta blocker? We know that there's chronic sympathetic activation with heart failure, and that chronic sympathetic activation can increase heart rate and trigger arrhythmias, can cause vasoconstriction, can stimulate the renin-angiotensin system, and that even the blood levels that are circulating in heart failure might be toxic to cardiomyocytes. And sympathetic stimulation can promote cardiac enlargement or myocyte dropout and replacement with fibrous tissue. Thus, if we could block some of these effects, that would seem to be a good idea. And indeed, in people, large studies looking at carvedilol and metoprolol have identified an improved survival time with carvedilol use compared to placebo, and improved event-free survival as well. And these drugs can be associated with improved ejection fraction, slowed cardiac remodeling, improved quality of life, in addition to prolonged survival. So they sound good. Why don't we use them more in veterinary medicine? Well, acutely, beta blockers are negative inotropes. So if you pick a dose that's too high, it can cause weakness, it might precipitate heart failure, it's not tolerated in all animals, and we're most likely to see the side effects in the sickest animals. And it turns out that these benefits can take 2 or 3 months before they start to be seen. So it's a little unclear when beta blockers should be used in animals with congestive heart failure. Some people propose maybe they should be used before the onset of heart failure, or only used in animals with concurrent cardiac arrhythmias, or maybe pimobendan should be started first and then beta blockers might be tolerated afterwards. I think we would sometimes use them in mild to moderate heart failure that's well controlled after an animal is already on medication, other cardiac medications, and is eating and drinking well and breathing okay, and it's a good owner-cater who's dedicated to the required dose titration. We would avoid giving beta blockers to an animal that had active congestive heart failure signs. So one of the keys for beta blockers in heart failure would be to start at a low dose and slowly increase the dose. So if we look at carvedilol, we might start at a low dose, make sure it's tolerated, and after 2 weeks, we would double the dose. And then after 2 weeks, we might increase by another 0.2 milligram per kilogram. And after 2 weeks, we might increase by another 0.2 milligram per kilogram until we get to a target dose of between 0.8 to 1 milligram per kilogram twice a day. Again, we'd start very slowly and in low doses if we're going to use beta blockers in animals that have heart failure. This is a summary of some of the things we've talked about for management of congestive heart failure in dogs. In asymptomatic dogs, pimobendan may be useful if there's moderate cardiac enlargement for mitral valve disease or cardiomyopathy. ACE inhibitors, especially if they're progressive left atrial enlargement, or if they have a high blood pressure, or if they have proteinuria in an asymptomatic situation. In the asymptomatic dog with significant heart disease, we would advise the owner to try to maintain a normal body condition score and start to talk to them about avoiding salty treats and potentially start to moderate sodium intake a little bit. Once an animal had mild to moderate heart failure, we would try to have an ACE inhibitor given ideally with twice-a-day dosing Pimobendan, furosemide, or potentially torsemide. Spironolactone would be one of the key therapies to try to get added in. And diet or exercise restriction, potentially including fish oil, as one retrospective study suggests improved outcome with fish oil administration. For advanced congestive heart failure, where the above drugs are no longer working and there's persistent heart failure, we would continue those above drugs and add in other diuretics, or go to higher doses of Pimobendan, perhaps use sildenafil if pulmonary hypertension is present, add in an arterial vasodilator like amlodipine if there's systemic hypertension, and there are other proposed therapies that may be helpful. For chronic management of heart disease in cats at the asymptomatic phase, we might use a beta blocker for a cat with hypertrophic cardiomyopathy and impressive left ventricular outflow tract obstruction. Again, talk a little bit about salty treats, although that's less of an issue in many cats, and try to maintain a normal body condition score. And if there's marked left atrial enlargement but no heart failure, we might consider an antithrombotic and/or an ACE inhibitor. With mild to moderate congestive heart failure, we'd use an ACE inhibitor, Pimobendan if there is no left ventricular outflow tract obstruction, furosemide titrated to the lowest dose needed to control signs of congestion, arterial embolism prevention, a variety of different choices there, and perhaps a diet change to one that's moderated in sodium or fish oil administration. For advanced heart failure, we'd continue the above and add in higher doses of Pimobendan, other diuretics, or possibly sildenafil. General rule of thumb for when to recheck a pet with heart failure and what to do, we would recommend a routine recheck 5 to 12 days after starting medications, to do history and physical exam to see if the owner is able to get the medications in. Has there been a clinical response? Is the owner noticing any problems? We would check kidney values and electrolytes at that stage. If the animal was still short of breath, we'd obtain thoracic radiographs. If there was arrhythmia, or if we were treating arrhythmia, we would obtain an electrocardiogram. To try to help assess hydration, we might get a Paxil volume total solids, and if the animal is on Digoxin, we'd obtain a Digoxin blood level approximately 8 hours post-pill. We might check a blood pressure, especially if they had previous systemic hypertension, or if they were a little weak or lethargic and might be hypotensive. And we would tell the owner to plan that we were going to make some adjustments to the treatment plan. And then for chronic management, we would recheck again and do those things we just talked about 5 or 14 days after any change in medication dose. Even if things are going well, we would recheck the animal every 2 to 3 months for a physical exam and talk to the owners, chemistry profile to check kidney valves and electrolytes, and then on the basis of those tests, there might be other diagnostics that are appropriate. And every 6 months, we would again like to examine the animal, talk to the owner, and probably repeat the echocardiogram to look for disease progression to try to preemptively adjust medications in an attempt to avoid a visit to the emergency room for acute worsening heart failure. Thank you.